Good afternoon, guys. How you doing? So far, so good. Any questions before we start? How was the exam? Reasonable? Any questions about the exam or anything? Any questions in general? Okay, so today we'll talk about drugs used for mycobacteria, tuberculosis, and we'll also talk about antivirals for hepatitis, mainly B and C. Most of the lecture will be about the mycobacteria and agents for antimycobacteria, because for the antivirals we covered the general mechanisms, so we're just gonna visit the examples of the drugs that act on the hepatitis B and C. Make sense? All right, so let's start with the antimycobacterial drugs. Let's start with a brief introduction. So the bacteria itself is a rod-shaped aerobic bacilli that multiplies slowly. The life cycle in vitro is 18 to 24 hours. Now, what do you guys think the impact of the slow multiplication of the bacteria? Why is that important? What do you guys think? Say it again. Slow progressing disease, that's a good point. Okay, so as you will see, there's actually something called latent infection. So people might be having the bacteria but don't signs. That's one thing. What else? What about the as far as using the antibacteria agents? Do you think we would need shorter or longer use of these antibacteria in this case? When the bacteria divides very slowly, do you think we should give the antibacteria for a long amount of time or short? For long, right? Because you want to make sure you cover all these bacteria that are multiplying. If the bacteria is multiplying slowly, then you have to administer the antibacteria for a long time, which is actually true, as we will see. Unlike all the other infections, or most of the infections, you take the course of antibiotic for how long? 7 days, 5 to 7 days, right? But in this case, you're gonna see months to years, okay? So you're gonna see 6 months, and then in some cases, you might have to administer the drug for 2 years, okay? All right, the structure of this bacteria is unique. It has something called mycolic acid, okay? So these are the fatty acids, actually, that they form the cell wall of this bacteria. And because they are fatty acids, they're gonna make it very difficult for drugs to penetrate, okay? So these are very long beta-hydroxylated fatty acids. And we will see that among the antibiotics that we'll use, there will be destroying these mycolic acids. That's one of the mechanisms for some of these antibacteria, okay? All right, so the Mycobacterium tuberculosis is the most common type of infection for the Mycobacteria, the Mycobacterium tuberculosis. It might cause, of course, the Mycobacterium infection when you have signs, but it might also, this bacteria might present in our body and show no signs. In this case, we would call it latent tuberculosis infection, LTBI. Okay, you guys heard of the TB test? Okay, what are we doing with the TB test? Huh? TB? Yes, the dermal test, yes. Yeah. What do you call it? Oh, okay, that's a new thing. Because I used to call, I thought it's always called TB test. Anyway, yeah, you could still call it the same way. Okay. So you take some parts of the, I guess, antigens under the skin, and then you're gonna see if the bacteria is reacting to that. What are we trying to do here? So if somebody has an infection, you're gonna see the symptoms. But this test is actually used to check if this person has latent tuberculosis infection. Okay, why? Because you're gonna have no symptoms, but you might have this bacteria in your body. It's not developed into an infection, and that's why you take this tuberculosis test. Okay. Now, if you test positive, this means that you have been exposed sometime in your life to somebody who has tuberculosis, but the bacteria has not developed. Should we treat this case or not? What do you think? Yes? No? Well, it depends on how severe the result of the infection is. Depending on the radius of the result of the test, if it's like indicating that you have like too much of this bacteria, then you could treat it. But if it's minor, you could actually live without having it taken a treatment. Okay, so you don't have always to treat it. But you will get to that with the pharmacotherapy faculty. Okay, any questions about that? Excellent. All right. Okay, now just some information. TB, tuberculosis, Mycobacterium tuberculosis is the leading infection causing death worldwide. So among all infections, this is the one causing death. The most bacteria infection that could cause death. And then about 2 billion of people are infected. 10 million of those are in the US. Now, tuberculosis, Mycobacterium, this is only one kind of bacteria. We have tuberculosis, we have Mycobacterium other than the tuberculosis. And so we have something called non-tuberculosis bacteria, NTM. Examples on those non-tuberculosis bacteria are the Mycobacterium avium intracellular, and then we have Mycobacterium chelonae, I guess, and then Mycobacterium abscissus. They can't make these names easier, right? And then Mycobacterium kansasi. There must be someone from Kansas who discovered this bacteria. And then Mycobacterium fortiatum. And then finally, Mycobacterium leprae, which causes leprosy. Yeah, finally something we could pronounce. Okay? So all these are different kinds of Mycobacterium other than the tuberculosis. So we call them non-tuberculosis Mycobacterium. Okay? Now, for today's lecture, we'll cover drugs that act on Mycobacterium tuberculosis, and at the end, we will talk about some drugs that act on the Mycobacterium leprae. Throughout the lecture, you would see that they mention that this drug acts not only on Mycobacterium tuberculosis, it could also act on other kinds, but you don't have to memorize that. It's spectrum of activity. I think it's too much information to memorize, but we'll get to that on time. Any questions so far? So far, so good? All right. Okay, now as far as treatment, we have, just like most of the infections, we have first line of treatment and we have second line of treatment. Okay? So there is something called first line drugs, and those are 4 drugs that we're going to know by heart because we're going to hear them. We're going to hear them a lot in this lecture. Then we have a second line of drugs, and those are usually less effective, but they are more toxic, and they are less extensively studied, so we don't have too much information about their effect on the Mycobacterium. But so why do we go to the second line? As you might guess, because some people might not tolerate the effects from the first line. That's one reason. Another reason is what? Resistance. I'm sorry? Yes. So first line, if it doesn't work, like in the case of the resistance, or if the side effects patient is not tolerating, then we switch to the second line of drugs. Okay? Make sense? All right. There are no drugs that are specific for the non-tuberculosis Mycobacteria. But generally speaking, in those cases, we would use things like macrolides, rifamycins, aminoglycosides. Okay? Sounds good? Any questions? Yes, Eric.
Would you have any idea about why would those 3 be the most frequently used, or not really?
Those 3 classes, macrolides, rifamycin, I'm sure it's about experiments. So especially with bacteria, it's easy to make an experiment. You could, grow the bacteria in a petri dish and then, try all these different kinds of bacteria and antibacterial agents and see which one is the most efficient, and then you could move it to the next level of clinical studies and see which one's more efficient. Okay.
I see. I got it. Okay.
Sure. Absolutely. Any other questions? Okay, so next we'll talk about the, that was a brief introduction, but now we're gonna talk about the chemotherapy for tuberculosis. As I said, we'll talk about tuberculosis and then the Mycobacterium leprae, for leprosy. All right, so to start with, as we mentioned, those bacteria, they grow slowly, which means that their treatment requires months to years, okay? Now, we also have the LTBI, the latent tuberculosis infection. Those are the infections that, where patients do not have any symptoms. So as far as treatment, in this case, you could either go with the 9 months of something called isoniazid. For the acronym for isoniazid is INH, okay, as a monotherapy for 9 months, okay, which is a lot, right? So it's going to be a problem with compliance. Or you could go with combination of isoniazid with rifampicin for 12 weeks, okay? So in the case of the LTBI. I would never expect you to memorize the dose, but I think you might need that for the therapeutics. So this is just to indicate how long it takes for the LTBI to be treated. Okay, it's either 9 months or 3 months, 12 weeks. Okay. Now, if you have an active infection, then you will need several drugs. You would start, as you will see, you would start with 4, and then you would reduce it to 2. Okay, so in the case of the active, you'll need much rigorous treatment. You will have to combine 4 agents together. And then in this case, the treatment would last at least 6 months. And then in some cases, when you have resistance, you might administer the drug for 2 years. Okay? So far, so good. Any questions? Okay. All right, so as far as resistance, you guys might learn this. How does resistance develop anyway? I'm not talking about the mechanisms, but mechanisms, as you might know, like mutations in the enzymes. But generally speaking, how does an antibiotic induces resistance? So let's look at this figure. So this is an example of using streptomycin, which is, by the way, it's not among the first line therapy, but this is just for example. And this is the day of administering the streptomycin, and this is the percentage of the bacteria that's resistant. At the beginning, in the first 20 days, you would see some like minor resistance, but then after 40 days, you have 25% of the resistant bacteria taken over. And then, of course, it's increasing, and when you reach 120 days, you have almost 100% of the bacteria is resistant to streptomycin. What does that indicate? What's going on? Yes, Eric.
Maybe it's just that you have a higher, the more days that you've been exposed within the specific medication, the likelihood of having a resistance gets higher.
So that's exactly true. The more time you're exposing the bacteria to this antibiotic, you have more resistance. But really, what's happening? Why is this true? What is it that's happening at the bacteria that makes more resistance? Do those resistance bacteria develop randomly, instantly, or what's going on? Over the time? Okay, so in fact, the resistance bacteria might already be present in a small percentage. But when you eradicate all the ones that are susceptible, guess what? The resistant ones will have all the remaining nutrients, and it's going to be the dominant ones. Okay? So you've heard of natural selection. So you're actually, by eradicating all the susceptible bacteria, you're providing a good environment for the resistant bacteria to take over and then become the dominant. And that's what's happening, in fact, in all the infections, not this one. Okay? Now, if you're lucky enough, you won't have this resistant bacteria strain among the infection. So it depends on, like, the infection that you have. Okay? Everybody get this concept? So the resistant bacteria, if it's present, by eradicating all the susceptible ones, this present bacteria, the resistant one, is going to take over, use the nutrients remaining, and grow and get stronger. Okay? Right. So I just wanted to explain how resistance develops. Now, ideally, you want to administer multiple drugs, multi-drug therapy to prevent this from happening. Also, if you see that there is no response, you would take a sample from the bacteria infection, you would take a sample, grow it outside, test it, and find what's the most efficient agent, antibacterial agent, and then use it, as we will talk about as well later. Any questions about that? Okay, so the key take-home message is there is usually a small number of organisms that are resistant. By eradicating everything else, you're allowing this small percentage to become the popular ones. All right. Okay, so now let's talk about the first line of therapy. Remember we said we have first line drugs, and we have second line. The first line are usually highly efficacious, and they have acceptable level of toxicity. They do have toxicity, but it's tolerable, acceptable in most of the cases, okay? Those drugs are isoniazid, rifampin, ethambutol, pyrazinamide. So make sure you know these combinations by heart. If we say the first line of treatment, we talk about those 4 drugs, and they are administered all at the same time. Okay, guys? Now, rifampin could also be substituted by one of these two, which is, in the same class, the same category of rifampin. So these are called rifamycins. Okay, so you could have isoniazid or any one of these 3, rifabutine, rifapentine, or rifampin, and ethambutol and pyrazinamide. So those 4 drugs are combined together and given to the patient, and this is the first line of treatment. Okay? Of course, this is going to reduce the chance of developing resistance when you combine those 4. Okay? Now, clinical improvements can occur in several weeks of treatment. Therapy is continued much longer to eradicate resistance. Of course, you might achieve the effect within the first few weeks, but you want to make sure that you eradicate all the bacteria. So you have to maintain the treatment for a long amount of time before you'd stop these drugs, which makes sense. I mean, like you take an antibiotic for a week, you might notice that within the first 3 days, all the symptoms are gone, but you still have to continue the antibiotic. Why? Because you want to eradicate all the remaining bacteria, because there are still some, but they're small amount, weak. I mean, so you have to continue the course of antibiotic. All right. Now, these are the 4 drugs we talked about, the first line of treatment. Now, in the first 2 months, you would administer those 4 drugs at the same time, and this is called the intensive phase. So we have 2 phases of treatment in this first line of treatment for these drugs. There is an intensive phase, and there is continuation phase. So the first 2 months, you would have to give all these 4 at the same time. But then after that, for the next 4 months, you would go into the continuation phase, which has only isoniazid and rifampin, and you would stop pyrazinamide and ethambutol. As you will see soon, the effect of these 2 is usually has no significance after 2 months. Okay, so you would stop these 2, because why taking drugs when there is no need or there is no effects? You might just have just stopped them, okay? Especially with the side effects they have. Okay. Any questions about that? So in short, we have an intensive phase and we have continuation phase. Intensive phase, you would start with all 4 drugs for 2 months, and then after the 2 months, you would continue with the continuation phase, which means you would only keep isoniazid and rifampin, and you would stop the pyrazinamide and ethambutol. Any questions about that? So far, so good. Okay. All right. Now, sometimes you might have bacteria that are resistant. So, in this case, as soon as you start the drug, this first line of therapy, at the same time, you would actually take samples of those bacteria to make sure that they are susceptible to the antibiotics we're using. But you would start the treatment, and then in the meantime, you would start also investigating, see which kind of bacteria do we have, and then see if they are resistant. Then you would have to switch to a different drugs. But you would start first with those 4, and then in the meantime, you also run experiments to find which antibiotics are more efficient, or is this kind of bacteria that we are having going to be susceptible to these 4 drugs or not. Okay? So apparently we have 2 kinds of resistance. We have something called multi-drug resistant, and we have extensively resistant tuberculosis. Okay? So in the case of the multi-drug resistance, we would switch to the second line of treatment. And those include these agents: aminoglycosides, fluoroquinolone, any of the first line drugs that remain active, okay? And then 1 or more of the cycloserine, ethionamide, and the para-aminosalicylic acid. So let me explain. So when you start this first line treatment for drugs, okay, at the same time you're also running experiments to find the kind of bacteria that you have, okay? Now, if this bacteria is found to be resistant to at least 2 of these 4, which are isoniazid and rifampin, if the bacteria is resistant to isoniazid and rifampin, okay, these 2, then you would switch to the second line of treatment. What does the second line of treatment include? It includes these agents, okay, aminoglycosides such as streptomycin, kanamycin, amikacin, or capreomycin, and these are all injectable agents. Fluoroquinolones such as levofloxacin, moxifloxacin, and whatever is remaining active among the first line of treatment, you could also keep, okay? Also, you could use cycloserine, ethionamide, and para-aminosalicylic acid. How do I decide which ones I would choose? How do I decide? Yes. So you start the treatment, but then you also run experiment susceptibility data based on, you take a sample from the bacteria, run experiments, see, which agents are these bacteria susceptible to. Okay, and then we decide which ones to go with. Okay. Now there is another case where you have extensively resistant tuberculosis. Then you would give drugs such as clofazimine, linezolid, or any other drug that has, provided efficacy, okay, based on the susceptibility data. Yes? Our definition extensive? I don't have exact definition. I would assume it would be resistant to all these second line, okay? So if you, in the case of the extensive, I assume that would be resistant to everything that we've studied. Then you would switch to the clofazimine and linezolid or any other drug that was found to be effective based on the data susceptibility. Okay? Yes.
So for second line therapy, is it also like a 4-drug regimen?
Excellent question. So for the second drug, is it always 4-drug regimen? Not necessarily. I would leave it up to the clinical faculty to explain like how you would go with which classes and which combination you would take. Okay, but the first line is very well established, these four, but then the second line, I guess it varies in the case. You have a question?
Second line regimen, if you're saying at least two drugs, for example, if I have in my case only one drug resistance, meaning like I'm keeping those drugs, right?
Excellent. Excellent. So the question is, for the second line treatment, if the resistance is only to one out of the four, then you would keep the first line of treatment. You would not switch. That's it. As far as I know, you wouldn't, based on what we studied. Okay, but you would switch to the second line only if you have not two. Not randomly selected two. We're specifically talk about isoniazid and rifampin. If the bacteria is resistant to both of these, then you will have to switch to the second line. Okay, Eric.
And I think I must have not caught it when Zeta had asked, but is it still going to be like a 4-drug regimen, like just substituting that with the second line, or?
Oh, that's the same question. So with the second line of therapy, it's not necessarily 4 drugs. It depends, and I think the clinical faculty would be best able to answer this question.
Okay.
But the first line is well established. You always have those 4 that you start with.
Okay.
Okay,
Okay. Thank you.
absolutely. Any other questions? Okay. All right, now adherence or compliance of patients when you have 4 drugs for such a long amount of time, as you can imagine, is that easy to do? No, it's very difficult. And so you have to and because of the severity of this disease and because of the importance of not developing resistance, because if you don't comply with the way the drug is taken, if you take it and you miss some of the antibiotics, then you're going to develop resistance. Because of the importance of that, there is something called directly observed therapy. What does that mean? It means that there will be members from the healthcare team that could watch you and make sure that you actually take the drug. Okay, and this service is usually provided by the most healthcare departments. So it's called DOT, directly observed therapy, to decrease the drug resistance and improve the curation rate. Okay? Why? Because of the importance, severity of the drug, because of the chance that the missing some antibiotics might cause bacterial resistance, because of the difficulty of maintaining these 4 regimens for 2 months and then for 6 months for 2 of them. So to make sure that patient is compliant, you could use this service. Okay, directly observed therapy. Make sense? Yes. So I don't know the exact details. I can guess. I know some examiners, they might send nurses to the home, like they might visit them, like maybe daily, or maybe check on them by the phone, or maybe have them come to their clinic. So it's one way to make sure they observe and make sure they actually take the drugs. Okay. Yeah. That's a good question. Any other questions? Okay, so let's start by the first drug among the 4 drug regimens, isoniazid. It's also for short known as the INH. Okay. So first of all, the drug has to be activated. So it's a prodrug. Okay, so in this form, it's actually inactive. It has to be activated by an enzyme called catalase peroxidase, for short CAT-G. So this enzyme is responsible for the activation of isoniazid into 3 different forms that attack the bacterial enzymes. Okay? Those forms, they attack 2 kinds of the bacterial enzymes. Those are the acyl or acyl carrier protein reductase, which is known as INHA, So INH, is from the isoniazide. So INHA, that's the first enzyme. But they also attack beta keto acyl ACP synthase, for short Cas-A. Okay, and those two enzymes are essential for the synthesis of the mycolic acid. Remember, we talked about the cell wall of the mycobacteria. We said they have mycolic acids. These are fatty acids. So those enzymes are essential for the synthesis of the mycolic acid. So if you inhibit those two enzymes, you're going to prevent the synthesis of the cell wall for the mycobacteria, and then that's how it dies. Okay? So we've talked about three enzymes. The first one, the one that's responsible for activating the drug. So this CAT-G, or catalase peroxidase, is going to convert isoniazide, which is a prodrug. It's not active. It's going to convert it into these active forms, and then those forms are going to attack those two enzymes. Okay? I think I have a figure here. So again, that's the isoniazide. It's converted, activated by this enzyme into this form, which is going to attack this enzyme and the other enzyme, which is not listed, which is responsible for acetylating a carrier protein that's important for building those mycolic acids, which is the cell wall of the bacteria. Make sense? Any questions? That's the mechanism of action. Any questions about that? So would that be selective based on the mechanism of action? It's very selective, right? Because we don't have mycolic acids in our body. We don't have cell wall, obviously. So we don't have those enzymes. And those enzymes, actually, all the three enzymes are present only in the mycobacteria. So this 1, 2, 3 enzymes are present in the mycobacteria, so that's very selective. Yet, those 4 drugs have serious toxicity. Why? Because they attack other parts of the body, and they might cause problems through binding to other sites, okay? As we will see shortly. Any questions about mechanism of action? All right, so as far as spectrum, that's just for your own information. So first of all, it's specific for Mycobacterium tuberculosis. It has some effect on the bacteria Kansasi. At susceptible higher concentrations. Most of the non-tuberculosis mycobacteria are resistant to INH. Okay. The drug is particularly effective against rapidly growing bacilli and is also active against intracellular organisms. So generally, we know that mycobacteria grows slowly, but if there are some bacilli that are rapidly acting, then the drug would be more effective, which makes sense, right? Because it's demanding the use of the enzymes more because of more rapidly developing, and so you'll have more effect of the drug. They act intracellularly. As you will see, some of these drugs act only extracellularly. So it's an advantage to have a drug that acts intracellularly because they could reach, inside the infected cells and then attack the bacteria, not only extracellular but inside the cell. Okay. Any questions about the spectrum? Okay. Resistance. Can you guess what would be the mechanism of resistance in this? Yes, Sophia. Exactly. One way is you could mutate the enzymes. So imagine if the bacteria has a mutation to this enzyme that's responsible for activating the drug, then that would be a mechanism of resistance. What else? Of course, you could also have mutations to the other 2 enzymes where the activated form of the drug attacks, right? What else? What are other mechanisms of resistance? The enzymes that are being attacked, they could actually be produced in a larger amount, okay? So if the drug attacks an enzyme, so one way of resistance is you could mutate this enzyme. Another way is this enzyme could be produced in larger amount, okay, such that the drug is not able to catch up with all those enzymes, and then that's another way of resistance. What do we call this This is called overexpression of the target enzyme, in this case, the INHA. So you may have overexpression in protein science means that you have so much synthesis of this enzyme. Expression means like transcription, translation of the drug, of the enzyme, such that you have much of these enzymes, okay? Also, you may have mutations in the proteins, or the enzymes that are being attacked, okay? So you could have mutations on the enzyme activate the drug, mutations of the enzymes that the drug acts on, or you might have overexpression, too much production of the enzymes that are inhibited. Make sense? Questions? Okay. Now, if this resistance develops, okay, if we know this bacteria has resistance to isoniazide, then there is something called cross-resistance between the isoniazide and something else called ethionamide. What does that mean? What do we mean by cross-resistance? So if the bacteria is resistant to isoniazide, it's going to be also resistant to ethionamide, okay? What does that tell us about the ethionamide structure and mechanism of action? It's very similar, okay? So as we will see later, because this drug will be covered at the end of the lecture, it actually has a very similar mechanism of action. Actually, the mechanism of action overlaps with the isoniazide because it could act through different mechanisms, and it's structurally similar, okay?
The same principle with acyclovir, right? You explained it to cross-resistance, I believe.
The same principle with acyclovir.
Yeah.
So generally speaking, anytime you have drugs that act through same mechanism, if there is a resistance to the one class, then there's a chance that the drugs within the same class that has the same mechanism, they will be also resistant, okay? You would see that among, for example, cephalosporins, right? So one drug resistant, if a patient is resistant to cephalosporins, then it's going to be resistant to other forms, so you'd switch to something different. Or generally the beta-lactams, for example, just like penicillins and cephalosporins. Make sense? Any questions? All right. Okay, pharmacokinetics, that's your favorite part, right? Which we don't have to memorize unless I emphasize something that very specifically. So the drug is orally absorbed. That's very nice. You don't have to worry about taking it by injection or anything. You can just take it at home. It has to be taken with food, especially with high-fat meals. It diffuses to all the bodies, including the cerebrospinal fluid. Okay, although it reaches in smaller concentrations in the cerebrospinal fluid. And finally, it's metabolized, or the metabolites appears in the urine, so it's excreted in the urine. So you don't have to memorize that, but I think every time I talk about how the drug is eliminated or metabolized, I emphasize if somebody has a renal function or hepatic function, you would watch for where the drug is excreted or metabolized, because then you would decide if I should switch the drug or keep it, okay? Or if you want to keep it, if you should adjust the dose or not. Concepts, right? Questions about that? Okay. All right, now metabolism of the isoniazide. Apparently, isoniazide goes through two steps, main steps. I mean, it goes through, let's call this 1, 2, 3, 4 different ways of being metabolized. But the main ones, there are major routes. You guys might remember this. There are minor routes, there are major routes. The major routes are the N-acetylation and the hydrolysis. Can you tell me which one of these four reactions are N-acetylation? Take your time, look at the reactions. Which ones, is it 1, 2, 3, or 4 represents N-acetylation? So N means something is going to be attached to the nitrogen. Acetylation and acyl group. And acyl group is COCH3. So I'm giving you hints. So this is an acyl group. Yep, number 2. Thank you so much. This step here is the N-acetylation. Okay. Right. What about the hydrolysis?
3.
Number 3. Hydrolysis is step number 3. Okay. Okay, so those are the two main routes of metabolism. Why is it important? Well, you guys remember whenever we talk about acetylation and acetylators, does that bring anything to your mind when we talk about acetylators?
Acetyl groups?
It's addition of acetyl groups, but then the process itself, or the people who perform the acetylation, does that bring anything to your memory? Huh? Something with alcohol? Not really.
Is it something to do with like liver metabolism?
Say it again?
Liver metabolism?
Liver. So it's performed in the liver. I'll give you a hint. Acetylators. There is something. There are two people. There are two kinds of people. Acetylators. It's in the slide. I know, but I want to stimulate your thinking. Huh?
Well, there's slow acetylators.
There is fast acetylators and there is slow acetylators. Okay? So there are people who are able to acetylate drugs fast, and there are people who are doing that slowly. So why is this important? If the major route of metabolism in this drug is acetylation, so what does that tell us to watch for when we administer the drug? For the fast acetylators, what does that tell us? What we should do? The dose, frequency. Thank you so much. Frequency. So for fast acetylators, you'll have to administer drug more often. Okay, but for slow acetylators, you would administer it less frequently. Okay, so the slow acetylators, you will have more of the parent drug in their circulation. And this here shows the half-life, and we have two populations. We have the slow acetylators, the fast acetylators. There is a half-life of about 1 hour. And we have the slow acetylators, slow acetylators, half-life of about 3 hours. Do not memorize the hours, but make sure you understand the concept that if you have slow acetylator versus rapid acetylators, then the half-life is going to be different, and so the administration of drug will be different. Make sense? Everybody get that? Okay. Make sure you also recognize which one of these pathways is the N-acetylation and which one is the hydrolysis. Make sense? Any questions? Yes.
Is that why, like, some specific medications, like, people who are like naturally in their bodies who are like slow acetylators versus fast ones? Is that why, like, there's like variances with like some people who can't take a medication versus some people who could?
So the question was, is that one of the reasons why some people can take medications, others don't? Well, this actually, this, I guess, a better example of what you said is the example of those who have the CYP2C19 and those who don't. Some people have the CYP2C19, also applies to 2C9 in larger amounts, others have smaller amounts. And so in some cases, when the drug has to be activated by those enzymes, for people who lack this enzyme, this drug would be inefficient. A good example is clopidogrel, Plavix. There are, so you should check, because Plavix is a prodrug, has to be activated by 2C. I can't remember if it's 9 or 19. 2C9. So if a patient is lacking this enzyme, guess what? He's taking the drug, but he's having no pharmacologic effect, and we cannot tell, because it's not one of the drugs you could see actually the signs, because it's taken as a precaution to prevent, thrombosis and
But the drug still accumulates, right? Even though the patient is not metabolizing, meaning like goes to the side effects, right?
That's a good point. So the drug itself, that it's not activated. If it has side effects, you would see, but there's no any noticeable signs that you could tell from the patient that, oh, he's having side effect from the parent drug. There's no such thing. So it's actually metabolized by other routes. Okay. So it gets excreted, but it never gets activated, and you're thinking that he's taking the drug, and you're protecting him while in fact you're not. So that's when the importance of pharmacogenomics plays a role. And so insurance nowadays are picking up on that, and they actually can cover these pharmacogenomic tests to see if this patient would be susceptible to this drug or not. Okay, but if you want to be safe, you could just avoid clopidogrel and give something else. Okay, make sense? All right. Okay, adverse effects. So these are actually serious and important adverse effects. So I would expect you to know all of them. Let's go through them one by one and elaborate on them because they are interesting. The first one is hepatitis. You will see that almost all the drugs that we see in the anti-mycobacteriums cause hepatitis. Some of them cause them in rare cases. Some of them don't cause them in not so severe case. But in this case, hepatitis in the isoniazid, the INH drug, is actually could be serious. Okay, and so it could also be fatal. Now this could become more dangerous if the patient age is greater than 35. So that's the first case. Okay, or if the drug is combined with rifampin. Why? Because rifampin also, as we will see, that might cause hepatitis, hepatotoxicity, but in rare conditions. So if you combine them, the chance increases. And guess what? That's what we do with the first line of therapy, right? We combine isoniazid with rifampin, right? We have isoniazid, rifampin, ethambutol, and pyrazinamide. So we are combining these. So you should be watching for these any signs of hepatotoxicity. And of course, if somebody drinks too much alcohol, then there's a chance that hepatotoxicity would also be more likely to appear. Make sense, guys? So hepatotoxicity is very serious with the isoniazid. It gets worse if you have any of these three conditions. So you should be watching for these cases. How do we watch for hepatotoxicity? Liver enzymes. Blood. Yeah. So you take blood samples constantly, watch for the enzymes in the liver, make sure they are within normal range. Okay. So that's the first side effect, and I definitely want you to know this by heart. The second side effect is something called peripheral neuropathy. What is peripheral neuropathy? It's like numbness or paresthesia in the hands and the feet. Peripheral means they are in your feet and hands. So towards, just like with diabetes, you might have this peripheral neuropathy. So you feel numbness or tingling in your. Why is that? Guess what? Isoniazid interfere with the enzymes that activates vitamin B6, pyridoxine. Okay? And so if you take the drug, it's going to prevent the activation of B6. And we know the importance of B6 in the synthesis of the neurotransmitters and in the nerves. And so if you take isoniazid, there is a chance you might develop peripheral neuropathy. How do we solve the problem? You would actually administer B6, but the enzyme is the drug is going to inhibit the conversion, the activation of the B6. How does that help?
Maybe you give the active form of it?
That's a good point. You could think of the active form, but in this case, we're just administering B6. But when you give more of the B6, the enzyme is going to able to inhibit all of the B6, and some of them are going to make it and be activated, okay? And so you would combine the isoniazid with 25 milligram to 50 milligram of the daily dose of the B6, okay? I don't care about the doses, but I do care about the concept of what's happening, why do we have to administer B6? I mean, what's the problem and how do we solve it? Okay, so just make sure you catch that. Say it again.
Why don't they just formulate it with B6?
Yeah, that's a good point. Well, I mean, we should probably design a new drug formulate these two together. Yeah, so that's a good suggestion. Any other questions? All right, so we talked about hepatitis, we talked about peripheral neuropathy. The third side effect is central nervous adverse effects. Can occur, including convulsions in patients prone to seizure. So people who are prone to have seizure, right? So isoniazid would actually make this more likely to happen. Okay, so CNS adverse effect. That's the third side effect we need to know. Questions about that? All right, and the fourth one is, oh, I just realized it's 1:54. You guys need a break. so you're yawning. Hypersensitivity. So there, of course, that's very common. Hypersensitivity, like skin rash, fever. So that's one of the common also side effects for isoniazid. Let me actually finish. Oh, I think that's the last slide, and then we'll have a break. Okay. What else? Now, as far as drug-drug interactions, you don't have to memorize interactions, as I said, but just understand the concept. Isoniazid can inhibit the metabolism of drugs such as carbamazepine, phenytoin, which are drugs for what? Seizure. So it's doubling the effect of increasing that seizure. First, through increasing seizure in the CNS, and if you inhibit the metabolism, oh, sorry, I got messed up things. So by inhibiting metabolism of these drugs would last more in the body. So their effect would be stronger. So you have to adjust the dose, okay? But of course, you may have side effects from these two drugs.
Even though carbamazepine and phenytoin are strong inducers, right?
Okay.
So isoniazid will be like stronger inhibitor, right? Like to inhibit those drugs.
So those are strong inducers. My guess, they would be inducing different enzymes, okay? So those drugs, they're probably, I'm going to trust that you said they are inducers, so they are inducing other enzymes. So they're affecting other drugs metabolized by those enzymes. But the drugs itself is metabolized by some enzymes. Isoniazid inhibits the enzymes that metabolize those two drugs. As a result, you would have accumulation of these drugs, and so you'll have more side effects from these two. And so you'll have to adjust the dose if you combine isoniazid with these two. Decrease the dose for those two, okay? Of course, in the case of phenytoin, it's very critical, the dose. It has a very narrow therapeutic index, so it's really difficult to make sure patients are taking the dose in the right range. You might, cause less or more of the phenytoin. If it's less, seizure is going to happen. If it's more, you get toxicity. So that's always very challenging, okay? All right, any questions before we have a break about this slide? So you know that you need to know all these side effects and how to solve this case and how the cases that enhance, causes higher hepatotoxicity, everything is clear? Any questions? Okay, let's have 10 minutes break and come back.
Sean, sorry that I had to end up leaving a little prematurely. Okay. Yeah, but I don't know if I heard of it, but she's been in the office. I was just like, it's like a fucking fish call. Yes. I texted her. I can get you one next time. Yeah, no. It's just because that like yeah, it's not that much, but I just wanted to go and let you know about that. I'll give you a chocolate bar next time. Oh, I could. You had it free.
All right, let's continue. Okay, so we talked about the first line of treatment. We've said there are 4 drugs What are they? Isoniazid, rifampin or rifamycin group, pyrazinamide, and ethambutol, right? So we covered isoniazid. Next, we'll talk about the rifamycins. Okay, so as far as the rifamycins, we have 3 examples: rifampin, rifapentine, and rifapentine. These are the structures, the differences between them. You don't have to memorize the structures. They're actually a microcyclic antibiotic, as you can tell from their shape. They're microcyclic. They're actually taken orally. My guess was when I saw these structures that I thought there's no way these could be taken orally, but these must be some of the exceptions. Okay, so these are taken orally just like with the isoniazid. So that's nice. You don't have to worry about having the patient staying in the hospital to take the drug when it's taken orally. Okay. All right. So in short, these are microcyclic antibiotic. They could be taken orally, and this is the second This is the second the second drug out of the 4 ones in the first line of therapy. Okay. They have broader antibacterial activity than the isoniazid because the resistance strains rapidly emerge during a monotherapy. It's never given in a single agent. Well, we already know that we administer 4. Mechanism of action: they block the RNA transcription process by interacting with the beta subunit of the mycobacterial DNA-dependent RNA polymerase. So of course we need to know the mechanism of action, right? So that's the mechanism of action. They block the RNA transcription process by binding to the DNA-dependent RNA polymerase. Okay. What does this mechanism remind us with? Antiviral. Thank you so much. Remember, guys, the antivirals we talked about, DNA-dependent RNA polymerase. Oh, is it? I can't remember the example. Yeah. Okay. Say it again. Oh, we have RNA polymerase and we have DNA. Remember, we had 2 classes. There's the DNA polymerase inhibitors, and there's the DNA dependent. Thank you so much. The RNA dependent, usually also known as the reverse transcriptase. Both of them are polymerase, because polymerase means that you're just adding nucleic acids next to each other and form a polymer. So they are RNA dependent and they are DNA dependent. In the case of the RNA, because you're going the opposite way, they call them reverse transcriptase. Okay? Usually you would go from DNA to RNA, but if you go from the RNA to DNA, then we call them reverse. Both cases are polymerase. So in this case, we have the DNA dependent RNA polymerase where this drug attacks, and so it inhibits the transcription. Any questions about that? Mechanism of action? Okay. Eric, sorry.
You said specifically it interacts with the beta subunit area. Would you mind explaining about that?
Oh, so any protein, if it has more than 1 unit, they give them names: alpha, beta, gamma. Okay. That's because, what else can you name them, right? It's like ABC, alphabet, all the numeric, the Latin, I guess, way. So if the protein has only 1 unit, there's no way to divide it. But if it has more than 1 unit, then you would divide it into like alpha unit, beta unit. And so in this case, it attacks the beta subunit. Okay? Proteins might have 3, 4, or sometimes just single. So you classify them or you divide them into alpha, beta, gamma, things like that. Okay? Sure. Absolutely. Okay. So that's for the rifampin. As far as spectrum of activity, it's bactericidal for both the intracellular and extracellular. It's nice, just like with the isoniazid. This agent acts on both intra and extracellular. Okay. Of course, it acts on the Mycobacterium tuberculosis. It does act on the non-tuberculosis mycobacteria, such as the Mycobacterium kansasi, and the Mycobacterium evum complex MAC, but you don't have to memorize the spectrum, as I said. They're also effective, as an antibiotic. It also has effects on other bacteria, not just the Mycobacteria. So it has many activity on the gram-positive and gram-negative organisms. It could also be used as a prophylactic for people who are exposed to meningitis, caused meningococca and Haemophilus influenza. But again, you didn't have to memorize the spectrum. It could also be active on the Mycobacterium leprae, although in the case of the leprae, we have two other agents that are preferred, dapsone and can't remember the other one. I will get to that. So that's, actually everything in this slide, you don't have to know except the intracellular, extracellular, and of course it's going to act on the Mycobacterium. The rest are just spectrum of activity, which we didn't have to memorize. Questions about this one? Okay. Resistance, as you can imagine, mutations to the genes that develop, produce the DNA-dependent polymerase, RNA polymerase, would result in mutations. Makes sense, right? Whatever the protein that's been attacked, if you have a mutation, it's going to have a different form, so that makes the bacteria resistant. Okay. Pharmacokinetics, orally administered, which is very nice. It goes to all fluids in the body. Concentrations enough are variable, often like 10 to 20% of the blood concentrations. So whatever concentration we have in the plasma, 10 to 20 of that will be in the cerebrospinal fluid, which is nice. It's metabolized by the liver, undergoes enterohepatic recycling. Even though it's metabolized by the liver and excreted in the liver, it could go through, remember guys, the enterohepatic recycling? Yes.
Yeah, I think what it is just that it gets metabolized by the liver, goes into the bile, then it gets excreted out of the bile. I think it's at the duodenum. And after that, I think it gets absorbed back in the intestines now?
Exactly, because what location, where is the drugs get absorbed mostly? In the stomach or the intestine? The small intestine, right? And that's where the bile gets excrete those metabolites or the drugs. Sometimes the parent drug itself is also excreted unchanged in the bile. And so there is a chance that the drug could be absorbed again and go through the same cycle. And so this is called enterohepatic recirculation or recycling, because it's the the GI and the hepatic, the liver, so it goes another round. Okay, why is this important? It just increases the duration of action of the drug, right? Okay. Any questions about that? Right, so nothing to memorize, just like concepts, okay? Okay, drug interactions. Rifampin can induce hepatic cytochrome P450 enzymes, as well as, let me mark this, as well as transporters. Can you give me an example of transporter that we always talk about? Transporters? PGP, thank you so much. So rifampin can induce those enzymes as well as the transporters, and therefore it has numerous drug interactions. Okay? So by inducing those enzymes and those transporters, more of the drugs will be metabolized or excreted, and so you have to adjust the dose. What's interesting is that rifampin, it could induce its own transporters. And so it has something called autoinduction. Okay? So why is this important? So if you take rifampin, after some time, rifampin is going to induce its own excretion through inducing the transporters that are responsible for excretion of rifampin. Why is this important, and what would that lead us to do? Yes, Eric.
Maybe what happens is that, like, if it's automated and it induces those specific proteins, maybe like specifically PGP, I'll say PGP. But again, what's PGP? It kicks out the medications. So what could be a problem is that maybe it'll shorten like the
Exactly. So by inducing its own transporters that are kicking out rifampin over some time, 1 to 2 weeks of dosing, the drug now is eliminated more. And what would you have to do in this case? You'd have to increase the dose. Okay? It's like tolerance, except you're not building tolerance. You just have the drug more eliminated, and so after 1 or 2 weeks, because of auto-induction, you have to increase the dose of the drug. Okay? So please make sure you catch this concept for rifampin, the auto-induction, and the fact that within 1 or 2 weeks you have to adjust or increase the dose to take care of that. Okay? As far as elimination, it's primarily eliminated in the bile and into the feces, and small percentage goes into the urine. We already talk about the importance of these things. Not to memorize where it's excreted, but just how is that applicable. Interesting side effect of the rifampin that I do want you to know by heart, which is rifampin, when it's excreted in the urine and in the feces, it actually changes the color of these secretions, and so you would see orange to red coloration of the feces and the urine. Very important for people to know that, right? As a counseling, if you don't tell them, what's going to happen when they see those? They might think they're bleeding or something or dying, right? So it's very important to mention that. Also, they could actually stain, because they go through the excretions of the eye secretions, so they might stain the contact lenses into orange red. So again, another important thing. So we need to know this by heart. Okay? So which drug causes stain of the contact lenses or coloration of the feces and urine? Good job. That was so short. I should have waited 2 slides and then asked the question. It's still in your short memory, yes. Oh, that's a good point. So my guess, it's the entire class, the 3 drugs, but I'm honestly not 100% sure. Okay? So, sorry. Okay. But speaking of the other classes, well, not yet. Adverse effects are generally well tolerated, unlike isoniazid. Isoniazid has more serious effects. Most common are nausea, vomiting, rash. Hepatitis, just like with isoniazid, can occur, but it's rare, and it increases in older patients, as we said, alcoholics, and in the case of people who already have some chronic liver diseases. And of course, if you combine it with another drug that could cause hepatitis, just like with the isoniazid. The only difference is isoniazid is more serious. This one here is rare, but since they both combined, so the chance of having hepatitis is higher. Make sense? Any questions about that? Okay, and let's see. We talked about this already, combination. So when rifampin is dosed intermittently, especially for doses greater than 1.2 or greater, then you might see a symptom that's like a flu-like syndrome with fever, chills, and myalgia. And sometimes it extends to acute renal failure, hemolytic anemia, and shock. So what does that mean? If you give that drug in small amounts, well, let me ask you this. Is it better to give smaller amounts of the drug or, repetitively, or wait long amount of time and give big chunk, wait long amount of time, big chunk? Which one is better? Let me add more information, because you might think it's more convenient. But if we have a drug that's likely to cause toxicity, is it better to give it small amounts over more frequent?
Yeah.
Yes, that's better. And so with rifampin, that's the ideal way. You should give it more frequently, smaller amounts. If you have to give it a large dose, and if you give them intermittently, like you space them out far from each other, then you're going to develop those symptoms, flu-like symptoms, and you might eventually get into acute renal failure, hemolytic anemia, and shock. Does that make sense, guys? Now, if you don't have those side effects, for the sake of having compliance and easy for the patient, then it's just once a day and make it easy on them. But if you have cases like that, then breaking it into multiple doses, small amounts, would be safer, okay? Make sense? Because then, instead of the drug fluctuating like that, it could just go like, fluctuating this way. And then you would have it would be within the therapeutic range. If this is the minimal effective dose or concentration, if this is the minimum toxic concentration, when you give it like frequently smaller amounts, then the drug sticks within this range. Make sense? Okay. So far so good? You're having fun?
Yep.
All right. Having fun at 2:20 p.m. after lunch, I believe you. All right. Drug interactions, we said that rifampin induces enzymes and transporters that have numerous drug interactions. You don't have to memorize, just understand the concept. Again, it's inducing those enzymes, and those are drugs that would be impacted by, there are so many, right? So many drugs will be impacted by rifampin. Now, let's see, through phase 1 and phase 2. And so as a result, this may necessitate higher dosage of co-administered drug. This would, requires higher dose because you're inducing the metabolism of these drugs, right? So you would have to increase the dose of those drugs because you have more of them now being metabolized. Or you could switch to a drug that's not affected by rifampin, or you could switch rifampin by, guess what? Rifabutine. That would be nice, right? Rifabutine is within the same class of rifamycin, and it would have less effect interactions. It's not zero, but as you will see, 40% less effect on the enzymes that are induced. So the effect of enzyme induction is 40% less, okay? Make sense, guys? Okay, so in short, rifampin induces enzymes. How do you solve the problem? Increase the dose of those drugs that are affected, or replace the drugs by something that's not affected, or replace rifampin by something within the same class, which is rifabutine, which has less effect on the enzymes. Okay? All right, the next one is rifabutine. It has actually very similar features with the rifampin, except in the case of the induction, it has less effect on inducing the enzymes. Okay, and so that would be nice. Spectrum of activity, let's see, TB confined with a human. Okay, so in the case of when people have a human, when somebody has the HIV virus, so they're actually taking antivirals, right? So this drug is preferred. Why? Because look at the list here. What do you see here? HIV protease inhibitors. So those people who are taking HIV protease inhibitors, because you want to make sure you are not, affecting those drugs, you could choose rifabutine instead. Okay? Because rifabutine will be affected by those drugs. Does it say the non-nucleotide phase? It doesn't say the example here, but I guess maybe it's one of these drugs that's also affected by the enzyme. Adverse effects similar to the rifampin. It might also cause uveitis, I guess, the redness or inflammation in the eye, skin hyperpigmentation, and neutropenia. Any questions about rifabutine? Okay. It did not talk about the redness, the coloration, but can someone check on that really quick? I'm just curious. I'm so curious. It does? What about the third one? Rifampicin. Good. That makes our life easy, right? Okay, so apparently those three classes or three examples of rifamycin causes the coloration of the urine and feces, which is very important consultation point for patients, okay? The third example has actually greater activity and a longer duration of action compared to the rifampin, which is nice, right? You don't have to administer it as much as frequent, and it has greater activity, okay? And so the combination of isoniazid and rifampicin could be taken once weekly for patients with LTBI and in select HIV negative patients with minimal pulmonary tuberculosis. In the case of the LTBI, we don't give higher or intense doses. It's once a week. So in this case, you could combine the rifampin because it has a long duration of action with the isoniazid once weekly. Okay. Any questions about the rifamycin? I think that's all for rifamycin. Any questions about the rifamycins? Yeah, Eric.
Is there something got to do with like a structure that makes rifapentine having a way longer half-life than
Oh.
radioactivity?
Let's look at the structures because I didn't think about that. So I think that might be it. This is the cyclopentane, cyclic. It's a hydrocarbon. It's going to make it more lipophilic. So, I would strongly believe that there is one responsible for the longer duration of action.
Okay, great.
Okay, sure. Any other questions? Okay. Now the third drug, all right, so far we covered 2 out of 4 in the first line of therapy. The third one is pyrazinamide, okay? So it's also orally effective, which is nice, okay? It's of course used in combination of these 3 for the 4 lines of therapy. Mechanism is not clear, so now you have a drug where you don't have to memorize its mechanism of action because it's unclear, right? It's enzymatically hydrolyzed so it has to be activated. So it's inactive, it's a prodrug. It has to be activated to the pyrazinoic acid through an enzyme that's named after the drug itself, pyrazinamidase enzyme, right? So it must be so specific to this drug. It activates pyrazinamide into the pyrazinoic acid, which is the active form of the drug, okay? Of course, as you can imagine, what would be the forms of resistance? Mutations to this pyrazinamide enzyme. If you lack this enzyme, or if there is mutations to the enzyme, then you won't be able to activate the drug, okay? Active against the acidic lesions in the macrophages. So it's nice that it acts on the acidic lesions because when the cells infected by TB usually have acidic environment. Distributes nicely to the body fluids in penetrating the cerebrospinal fluid. Just like with isoniazid and the rifamycins, it has liver toxicity. Now that's an interesting side effect. It might actually cause uric acid retention. Pyrazinamide could cause accumulation of uric acid, okay, but it rarely precipitates to gout attack. However, if somebody has a gout and they're being treated for gout, so what's the chance of that they're getting a gout attack if they take this drug? It's going to be higher, okay? All right. So far, most of them have this liver toxicity. Pyrazinamide is unique about this uric acid retention. I think there's another one that also affects the uric acid excretion. It inhibits the excretion of uric acid, and it also causes, increase the chance of having the gout. Right. Most clinical benefits occurs early in treatment, which is why we stop it after 2 months. You guys remember with the 4 drugs we talked about, isoniazid, rifamycins, let's say in general, pyrazinamide, ethambutol, you administer them for 2 months in the intense phase, and then you stop the pyrazinamide and the ethambutol, and then you continue with the other two. Why do we stop the pyrazinamide? Because apparently, clinically, it shows that all the effects appear early within the first 2 months, and so there is no need to continue them. Whether you continue or not, you achieve the same effects. Make sense? So if you don't get effects after the 2 months, why keep in the drug, okay? Any questions about that so far? All right, the fourth one, ethambutol, bacteriostatic. It inhibits this enzyme, arabinosyltransferase, which is an enzyme important for the synthesis of the Mycobacterium cell wall. So that's an enzyme important for the synthesis of the cell wall. And so by inhibiting this enzyme, you're breaking the synthesis of the cell wall. Of course, it's used in the combination of these three, with the first line of therapy. Maybe discontinued if the isolate is determined to be susceptible to these three. Now, if you find that the bacteria is susceptible to these three alone, because remember we start the four drugs, first line of therapy, and then in parallel we run those susceptibility tests. If we find that there is no need to administer this drug, you could just keep those three, depending on the strain. Some strains would be susceptible to these three alone, okay? Well distributed to the bodily fluid. The CNS penetration is minimal, okay? Yet it is adequate to treat tuberculosis, meningitis, which is questionable because the drug does not penetrate too much in the CNS, yet it's still sufficient enough to treat the tuberculosis meningitis, which is inside the CNS, cerebrospinal fluid. Okay, which is questionable. This is one of the things that you see clinical trials proving something, but you might not be able to rationalize it or explain it with like what we know from about the drug. Okay. Questions? So you definitely need to know the mechanism of action. This is a concept, of course. This is also a concept, not memorization. Questions? Okay. Both the drug and its metabolite excreted in the urine. That's an important side effect for the ethambutol, which is it actually causes optic neuritis and makes it the patient unable to discriminate between the red and the green color. Okay, and so throughout the time that the patient is taking this drug, what should we do? We should always have them check with ophthalmologists to make sure that they are, they check their vision, acuity and the color discrimination periodically. Okay? So that's an interesting thing I definitely want you to know. If someone takes the drug, you definitely want to counsel them that this could occur, and then they should frequently check with ophthalmologists. Is that color blind? What is that color blind? You cannot differentiate. I remember there are two colors, people green and red, the same as. Okay, so I should say color blind here.
But they can't drive.
They can't drive because, of course. Oh, the lights makes sense. Thank you. I never thought about that. Okay. Nice. Okay. That's a drug that causes also inhibition, decreased excretion of the uric acid. Okay. So just like with the pyrazinamide causes retention of the uric acid. The same thing here. Ethambutol causes accumulation of the uric acid, and so caution should be exercised in people who have gout. Okay. So I definitely want you to know that about these two drugs with the uric acid accumulation. Okay. Make sense? Okay. Questions? Yes.
See, this drug, right? You stop it along with the pyrazinamide too, right?
You do.
But why is that? Like, is there a specific concept of the reason why?
I would. So it's not explained, but I guess it would be for the same reason. Like they probably found that whether you continue it or not, it's just the maximum clinical effect has been achieved within the first 2 months. This is my guess, but I'm not 100% sure.
Okay, got it. Thank you.
Sure. Any questions? Okay, this is a summary, of course. Only the ones we highlighted and emphasized effects you need to know, so I'll just skip this table. All right, now that we're done with the first line of therapy, we have drugs that are chosen in the, to substitute those in the first line that were found, for example, ineffective. Okay, so we'll go through these drugs, mechanism of actions, and the unique side effects. Okay, so we have streptomycin, paraminocytic acid, capreomycin, cycloserine, ethionamide, fluoroquinolones, macrolides. Okay, so, and of course, as we said before, like in case, like those are less effective and more toxic than the first line agents, but if we have to go to the second line, then we have no choice. The first one is streptomycin, which is an aminoglycoside. Okay, it was among the first ones effective against tuberculosis. So this was the first among the first ones discovered to treat tuberculosis before they actually found the other ones to be more effective. Okay, so historically this was the first one. Okay, it has appeared to be greater against extracellular, so acts mostly on extracellular. I don't really expect you to memorize which drug acts extra or intracellular. Infections due to streptomycin resistance organism may be treated with. Okay, so if a drug is resistant to that, then you could switch to kanamycin or amikacin, which is to which these would remain susceptible. The next one. So any questions about streptomycin? I mean, those second line, there's not really much information. We just have to visit their mechanism of action, and maybe if there is something unique, I will highlight it. Para-aminosalicylic acid, another one of the tuberculosis from early 1950s until 60s. It was used, was a standard 18-month treatment regimen, largely replaced by ethambutol for drug susceptible, remains an important component of many regimen for the resistant. In the case of resistance, of course, makes sense. We've said all that already, nothing new here. Capreomycin, this has to be given parenterally, but you don't have to memorize which one's orally, which one parenterally. Because it's a polypeptide, of course, anytime you have polypeptide or protein, then you cannot take it orally. It will be damaged by the stomach acid and enzymes. Reserved with the drug resistance, we know that already. Carefully monitoring to minimize nephrotoxicity and ototoxicity. Honestly, I think we had good amount of side effects, so you don't have to worry. Sure. Cycloserine, again, orally active, distributes throughout the body, excreted in the urine, accumulation occur with renal insufficiency. Of course, it's excreted in the urine. Adverse effects, CNS disturbances, just general. I mean, I'm not gonna I think we had, like I said, we focused on the other side effects. Okay, ethionamide. What did we say about ethionamide? Remember? We talked about ethionamide. A structure similar to isoniazide, and it has overlapping mechanism with isoniazide. And so if bacteria is resistant to isoniamide, then there is a cross resistance with ethionamide. So there's a good chance that bacteria would be also resistant to ethionamide. Okay, so like we said, structure is similar, the same, overlapping similar mechanism, overlapping also resistance, distributes widely through the cerebrospinal fluid, metabolism extensive in the liver. You know what that means, right? If somebody has hepatotoxicity, liver failure, we know what to do. Adverse effects, so you would see hepatotoxicity as a very common one, and then other nasty side effects as well. So I'm not gonna even name them, so you don't have to worry about them. Fluoroquinolones, the most, specifically moxifloxacin and levofloxacin. In case you're wondering why these two, well, it's trial and error. There was, they probably tried everything and then found that these two are the ones most effective. Of course, all the ones that we started talking about in the second line of therapy, they are specific in the case of the multi-drug resistance. Now, some of the non-tuberculous mycobacterium might be susceptible as well. And then we have macrolides such as azithromycin, clarithromycin, also included in the anti-M infections such as MAC. Azithromycin may be preferred for patients at greater risk of drug interactions. Why? Because clarithromycin interacts with so many CYP enzymes. Makes sense, right? So if you have to go with the macrolides, you would prefer azithromycin over clarithromycin. Why? Because clarithromycin affects enzymes more. I mean, it's not that azithromycin doesn't. It just clarithromycin impacts enzymes more than azithromycin, okay? I don't even know how to say that. Bedaquiline? Okay. It's an ATP synthase inhibitor. Again, the MDR tuberculosis taken orally, side effects, QT prolongation. So anytime we hear QT prolongation, what does that mean? Arrhythmias, thank you so much. QT prolongation, the heart, so it means could cause arrhythmias. You don't have to memorize that. I just like to remind you when you hear, because it's common actually, there's some good amount of drugs that could cause QT prolongation. It's an agent for this enzyme, so any drugs that interfere with this enzyme, of course, are gonna cause drug-drug interactions. And that's a summary of all these drugs in the second line of therapy. All right, any questions before we talk about leprosy? Need a break? Yes? No? Let's vote. You need a break, raise your hand. If you do not need a break, raise your hand. Okay, we'll continue. All right, so leprosy, it's caused by the Mycobacterium leprae, of course. And there are two drugs that are used, dapsone and rifampin. Rifampin we covered already, so we're only going to talk about dapsone. We also have the clofazimine, okay? So I think we're going to talk about it as well. Okay, dapsone. So I'm going to skip to the mechanism of action and see if you'd recall which mechanism of action does that. We've seen this mechanism of action before. There is para-aminobutyric acid converted by the dihydropterine synthase into this drug, which is converted into, this agent, which is further converted into that, which is further converted into this, which is important for the DNA synthesis. You've seen that before, right? Where?
Isn't it in like the folate inhibitors?
Say it again?
Isn't it like the Bactrim and the folate?
Excellent. Bactrim, sulfonamides.
Yeah.
So sulfonamide was acting here, and then we have the trimethoprim acting here, right? So we'll focus only on this, because that's what dapsone is doing. So dapsone is an inhibitor to this enzyme, dihydropteroate synthetase, which is the same enzyme where sulfonamides acts on. Yes? Am I sorry again? Oh, pregnancy. Okay, so this enzyme actually is present. I'm not saying it's with or without pregnancy. I'm just explaining this mechanism. This enzyme is important only for the bacteria. Our body starts from here. I think somewhere here. So we take folic acid and jump immediately from here. We don't rely on these previous steps. Only bacteria needs those steps. Okay? So that's a good mechanism of selectivity. Okay? That's being said, I'm not sure if the drug is safe in pregnancy or not. Make sense? Okay. But that's an interesting question. So, bacteria has to make those into the folic acid and then carries on. Our body does not rely on these mechanisms. It takes it externally, like take folic acids from outside resources, and then use it to carry the DNA RNA synthesis, okay? So that's a nice way of having the drug selective to the bacteria. Okay, so dapsone, again, similar to the sulfonamides, even structurally similar to sulfonamides, okay? Inhibits the dihydropteroate synthase. It's active on Mycobacterium leprae, of course, to treating leprosy, and some resistant strains may be encountered. Of course, if you want to guess, how would resistance develop? Mutations to this enzyme, or maybe maybe overexpression of this enzyme. It's also used in treatment of pneumonia caused by Pneumocystis jirovecii in immunocompromised patients. So this is a spectrum of activity, but we won't have to memorize. Okay, so that's the mechanism of action. So the drug goes, distributes very well, but then it concentrates into the skin, which is obviously a good reason why we use it for leprosy, right? As it distributes to the body, it accumulates into the skin, which is nice. It goes through hepatic acetylation. Remember acetylation? We have fast acetylator and rapid and slow acetylators, so just something to keep in mind, okay? Eliminated into the urine, so if somebody has renal failure, you want to keep that in mind. Adverse effects include like hemolysis, especially for those who have glucose 6-phosphate dehydrogenase deficiency, methemoglobinemia, and peripheral neuropathy. Again, I won't expect you to know the side effects. It's too much so far. Okay, any questions about that? Dapsone? So mostly the mechanism of action, really. That's it. Okay, clofazimine, the second one. We said dapsone and rifampin, and adding the clofazimine in case of the multi-bacilli cases. Since we covered rifampin already, we're going to talk about clofazimine. So it involved DNA, binding to DNA, mechanism of action through some reduction oxidation properties leading to generation of cytotoxic oxygen. So the drug goes through some oxidation reduction, produces cytotoxic oxygen radicals that binds to the DNA and then cause the damage. That's its mechanism of action, okay? It's bactericidal to the M. lepri. It has potentially useful activity against the Mycobacterium tuberculosis and the NTM. Orally absorbed, accumulates in the tissue, allowing intermittent therapy, but do not go into the CNS. So far, so good. Questions about the clofazimine mechanism of action? All right. Patients typically develop pink to brownish, black discoloration of the skin. It should be informed in this evidence. So I think that's a unique thing to keep in mind for clofazimine. So if you take clofazimine, you should warn patients that the skin might change from pink to brownish, black discoloration. So it's good to inform patients about that. So that's something I would expect you to know. Okay. Eosinophilic and other form of interest sometimes require surgery. So like some types of these leprosy, they might actually require surgery, like if that's these kinds of infections. The drug has anti-inflammatory effect besides and anti-immune activity, which is nice in this cases of erythema leprosum, which is a case of so the drug could go through some cases like some inflammations that are described by this. So this drug is nice because it causes anti-inflammatory and anti-immune activities for patients who develop these kind of inflammations. Okay, any questions about the clofazimine? Questions? Okay, so that's it for the antimycobacterium. The next is antiviral. It's very short. It's like it would take probably 20 minutes. It's 2:50 now. Should we have 10 minutes break? Come back? Break? Okay, let's do that. Okay, 10 minutes break and then we'll come back and continue. So I'll see you at 3 o'clock. Yes, absolutely.
Regarding, I don't know if you
skipped over these or I blanked out. Do we have to know anything about these?
So it depends, I guess.
Wait, hold on, let me.
Let's go through them one by one because I'm afraid.
Okay, yeah.
So
So streptomycin.
let's see. Not really. I mean, it's just the fact that it's aminoglycoside. You can tell that from the name,
Yeah.
but there is nothing really.
Okay, the next one is this one.
No,
No.
we know already that all these second line of therapy are used in the case of the MDR, so it's nothing like
Okay.
nothing new.
Okay, let me.
Nothing really.
No.
No.
I think those were all my questions. Oh wait, no, this.
Just the fact that it's similar in structure and mechanism of action to the isoniazide, and the rest of the side effect you don't have to worry about.
Wait, but this one it has. It's not identical,
Overlap.
but there's an overlap in
Overlap with
resistance. So like the mutation. Or whatever the resistance is for isoniazid.
Yes, well, I mean, because of that, because they're similar in structure and mechanism of action, they overlap in resistance.
True.
So
Yeah. And you said not the side effects. And
nothing.
just maybe like the examples. Okay, and the rest I was there for. And then there was these. I think this is first line drugs. Okay, so the isoniazid, that's the mechanism. Do we have to know anything about spectrum?
No.
No, right?
Never.
Resistance is the mutation.
So,
Would we have to know all three?
well, I mean, it's a common sense. Like, what enzyme responsible for activation, so mutation will damage that. Enzymes are being attacked by the drug, so mutations will also cause resistance. The third one is sometimes you have overexpression, like too much production of the enzymes that are being attacked.
So it's too much.
So three mechanisms make sense. They make common sense. I would expect to know that.
So if there's three mechanisms, there's technically three mutations because it will target each one.
So
Or it'll
first two,
affect.
the first two are mutations, but to different enzymes. The first one is mutation to the enzyme that activates a drug. The second example are mutations to the enzymes that are being attacked by the active form of the drug. Okay?
Okay.
The third one is overexpression, which is overproduction of the enzymes that are being attacked by the drug. So when you have too much of these enzymes, they overcome the drug. Make sense?
Yeah. Okay, and then pharmacokinetics. Oral.
Not really. No.
No.
I mean, because there's too many things to know which one's orally versus parenterally. So,
And the effects, adverse effects.
yes, every single thing because we like literally explained
Each one.
each one and how we could address it.
Okay, so I'll just go over this one on my own. But this one,
This is important too. We talked about there's so many routes of metabolism. Those two are the major. Acetylation is important. Some people could be rapid or slow, and that's going to affect their half-life, which is going to affect the frequency of administration.
okay, so it can affect frequency.
Yes.
So like if you give it every, like twice a day or like every 6 hours or something
Exactly,
like that.
because half-life is different, which means it's going to impact so many things, such as the frequency.
Okay. So so a rapid acylator has a short half-life, so you're gonna give it more frequently.
Yes,
Right.
because those people metabolize the drugs quickly, so it's going to be excreted quickly, so you're going to give more frequency.
Okay. Okay.
And make sure you recognize which one of these are acetylation, which one hydrolysis. So basically, this one here is the acetylation. You see the acetyl
Acyl group, yeah.
and this is hydrolysis. You see the hydrolysis between splits here.
And what would be these two?
These are additional minor routes of metabolism. So we have 4 routes. This is the major. Sorry,
Acetylation.
these two are major. So acetylation and hydrolysis are the 2 major.
Okay. Sorry, my watch is.
No, that's fine.
Oh, that's not okay. and then rifampin, I was there. Okay, thank you so much.
Absolutely.
What's up? I had a question. So after the midterm, I was remembering one of the questions asked. I think it was this: why do you combine antivirals?
Yeah.
So was there three answers as the choice or two? Because I remember choosing two. I didn't choose the option. I think if I remember correctly, I didn't choose the option to reduce resistance because it didn't say it anywhere in the notes. I just wrote that we combine it because it would reduce the dose and it like acts upon different I think it was like mechanisms. So like
Okay, so I can't remember the exact question, but it actually decreases resistance because generally, anytime we have antibiotics, and if we combine them, you definitely decrease that decrease of resistance. Why? Because imagine, let's say one antibiotic eradicates 90%. Another one will probably overlap, but then would eradicate some of the remaining 10%. So the chance of having less resistance is much.
so the question was for antivirals, I think.
Yeah.
And I didn't know that because it didn't like say it straight out in the notes. So I thought maybe you could induce resistance. I don't know. Is it possible to look at the question?
I mean, the nice thing is those were partial, so you wouldn't be penalized for the entire question. But regardless,
So was there
I checked all the questions already, and
because I don't think it said it in the notes straight out. I was rereading the antiviral lecture. I know I'm not. I'm usually not the annoying student, and I usually do understand the concepts. But
the nice thing is mentioned that even if it's not, because it's one of the
you mentioned it in the anticortisol lecture. Because I write a release. I don't know. You mentioned it for what? I could show you my notes for antivirals. I was looking. There's no way you could reconsider it.
that's how we just I only had like
You had a lot. You had the most actually.
Yeah,
Like
yeah.
20 maybe.
this
I
is
don't know.
fascinating. I had a lot. So
I knew your material. It just bothered me because like it didn't like say straight out. I didn't write it like because we also learned in antibiotics and the other most like something when you use two antibiotics it could induce resistance. I wasn't sure. I was just getting in my head too much, so I didn't know what to choose. So I said, you know what? You didn't learn it like straight out. It wasn't like straight out. I reviewed the notes like again now and I was trying to follow all that.
I could double check.
But I'm just saying like I don't think there's in the slides. No, it's okay. You could check. I'm trying to check to find it. It's just
Just the fact that I will check this out.
sorry for bothering. I understand regardless. It bothered me because I wanted to understand the question also. It was like in my head. And I think I got that wrong. I still didn't review my exam. I'm waiting to review not this Thursday, next Thursday. mentioned in anti-protozoal stuff. I didn't study that. That's from fine.
I checked the statistics for that much. Just check many images to this.
Sorry for being
No,
like
that's fine.
annoying. I just.
Dr. Kashan, I don't know what these are. I think they might be mints. I didn't know they were mints.
That's good. That's good.
I just because what happened was is that like I don't know. I found these right in like at the local marine services. I wanted to go and get you some of that. It's just mints. I'm not trying to signify that you have a bad breath. That's what I was just trying to say. I'm not trying to signify
I was
that.
gonna ask you, is it that bad?
No.
Okay, we made it so far. It's 3 p.m. So next we're going to talk about the antivirals, the hepatitis antiviral. So we actually, since we covered the mechanism of antivirals, we're not going to stress so much on the mechanisms. We're just going to refresh the mechanisms quickly and then talk about the drugs. But so to start with, hepatitis viruses, we have 4 kinds of hepatitis. We have hepatitis A, B, C, D, and E. Actually 5 types, not 4. I have to count correctly. But the most common ones are actually hepatitis B and then hepatitis C. Hepatitis B is a DNA virus. Hopefully you still remember the DNA viruses. Hepatitis C is an RNA virus. Okay, and so they cause things like chronic hepatitis, cirrhosis, and hepatocellular carcinoma, and are only hepatic virus infection for which therapy is currently available. So these are the most common. So obviously you'll have drugs for hepatitis B and C. Hepatitis A, for example, is a commonly encountered infection caused by oral ingestion of the virus, but it's not chronic disease. Okay, so the most serious ones we worry about are B and C. Obviously, for obvious reasons, C is the most common, followed by B. Okay. All right. So hepatitis B can be treated by pig interferon. You guys remember the pegylation, polyethylene glycol? So interferons, if you add the polyethylene glycol, we call them pig interferon. So pig interferon alpha. So apparently, as we have alpha, beta, and gamma interferons, and there is the alpha 2A. This one here is useful in treating hepatitis B, and then it's injected subcutaneously, obviously, because it's a protein, and it's given once weekly. Okay. There is a note about hepatitis 2B, which is given intramuscularly or subcutaneously 3 times a day. That's also useful in hepatitis B. However, the pegylated form of the interferon alpha 2A has similar or slightly better efficacy with improved tolerability. Okay, so it's just a comparison between the ones that pegylated, the ones that's not, and the one that is 2A and the one that's 2B. Okay, so apparently the pegylated form of the 2A has better efficacy and tolerability. Okay. Other drugs for hepatitis B are lamivudine, edifovir, entecavir, tenofovir, and telbivudine. We will cover some of them, okay, throughout today's lecture. Any questions about interferons? Okay. Now for hepatitis C, preferred treatment is combination of pegylated interferon 2A and the pegylated interferon 2B plus ribavirin. However, I have to confess that I would leave those clinical informations to the therapeutic people, okay? Because I'm sure they have better, more updated information about what's the most common protocol to be used. So for my portion, I'll focus on mechanism of actions, side effects, medicinal chemistry, okay? But when it comes to like the combinations of treatments and things like that, so, you know, I'm not gonna ask you about those because it's not my area, and it's good to learn them from the therapeutic faculty, okay? Right. There's something interesting about the hepatitis C, which is it has actually a genotype. There's something called genotype hepatitis C, okay? This specific genotype has a protease called NS3-4A protease, okay? And so there are specific drugs that target this protease enzyme, and those drugs are the boceprevir and the tenofovir. And so in the case when you have the genotype 1 of that hepatitis C, then you could use those protease inhibitors and should be added. Make sense? So that's a concept. Some of the hepatitis C species have this protease that's called NS3-4A, and so for those kind of genotype 1 hepatitis C, you would give the protease inhibitors that acts on this protease. Make sense? Okay. Any questions so far? Okay. All right, so this is a review for the mechanism of actions. We've seen those already. Some of them act on the DNA polymerase, others act on the reverse transcriptase inhibitors, which are of two kinds, the nucleoside and non-nucleoside. And then we have those that affect penetration, such as interferons. So interferons belongs here. And then we have neuroamidase inhibitor, we have protease inhibitors. So I think the ones we cover are the drugs we'll talk about today belongs to one of these classes, okay? 1, 2, and 4. We will see protease inhibitors, we already talked about interferons, and then we have drugs that act on the DNA polymerase inhibitors, okay? So I'm not gonna review the life cycle and the drugs because we talked about that already. All right, so interferons, we talked about them already, but let's talk more, I guess. So their mechanism of action is they interfere with the ability of the virus to infect the cell. So they interfere with the penetration. Just to remind you, interferons are actually our nature defense. That's what our body does when it's infected by a virus. It has interferons that are produced naturally to increase the resistance of our cells to the virus penetration. And knowing that interferons could perform this protection, we could design them, synthesize them, administer them as a drug to amplify this effect and prevent the virus penetration, okay? There are three kinds of interferons, alpha, beta, and gamma, as we said. And then we also talked about interferon alpha, and there are kinds of interferon alpha 2b. And then soon we'll talk about the pegylated interferon by adding polyethylene glycol, okay? How do we synthesize those interferon? There's a technology called recombinant DNA technology. You guys heard of recombinant DNA technology? So basically you're using bacteria, inserting the DNA piece that synthesizes the interferon into the bacterial DNA, and then rely on the bacterial replication and ability to produce those proteins and collect them, okay? That's a very efficient way. Interferon alpha 2b has been approved for treatment of hepatitis B and C. Besides condylomatia, whatever that is, and some cancers by hairy cell leukemia. Okay. So we don't have to worry about the spectrum. All right, so the pegylation part, and that's an important concept. You guys remember the importance of the pegylation? Increase the duration of action. How?
Because it's very lipophilic,
So that's what we would think. Making the drug more lipophilic increases the duration of action, but this is not the case. In fact, the polyethylene glycol is actually polar. The reason they increase duration of action is by prevent its metabolism and its excretion. So by adding the polyethylene glycol to the protein, this protein is not recognized by the enzymes, it's not excreted, it's not metabolized, so it stays longer in the body. Additionally, it delays the absorption. So now you have the drug being absorbed slowly. It's like extended release. right? It's slowly released, and then it stays longer in the body, it's not eliminated, and so that's going to increase its duration of action, okay? So just make sure you catch these concepts, okay? The importance of the pegylation. Here are some applications of the interferons. We care about the B and C. The rest are just spectrum of activity, which we won't worry much about. We already talked about mechanism of action. They inhibit the penetration and the induction of the host cell by inhibit RNA translation, leading to degradation of mRNA. Pharmacokinetic interferon are not orally active, of course. Anytime we have proteins, they won't be stable, so we have to get them intralesionally or subcutaneously or intravenously. Let's see. Little active drug found in the plasma, and its presence is not tolerated with clinical responses. Cellular uptake and metabolism by the liver and kidney account for disappearance of interferon. Negligible. Okay, so we're talking about interferon, and these are one of the problems, that there's little drug that stays in the plasma because it's being uptaken by the cellular, and then it's also metabolized by the liver and the kidney, okay? So that's when the importance of the pegylated forms, okay? Adverse effects of the interferon are flu-like symptoms. I think we've seen that before with the antivirals, right? Adverse effect of the interferons. Fatigue, mental depression, and there is also some other dose-related toxicities. So these are toxicities that could appear at higher doses. I don't think you need to memorize these. This is just to be aware of them. Bone marrow suppression, severe fatigue, neurotoxicity, autoimmune disorders, cardiovascular problems. All right, so we're finished with the polyethylene glycol, pegylated interferons and interferons. Next, we'll talk about other drugs, other antiviral. So the first one is lamivudine. The mechanism of action we studied already. This is a cytosine analog. You guys remember the term false substrates? Excellent. So this is a prodrug that has to go through how many steps? 3 steps to be converted into the triphosphate, which mimics the cytosine and then binds to the DNA and then blocks and terminate the polymerase. So it has to be converted phosphorylated to be the active form, acts on the DNA polymerase. So we already talked about mechanism of action already. Let's see. As with many nucleotide analog, intracellular half-life terms is many hours longer than the plasma half-life. So because it binds here with the DNA, so even though the drug disappears from the plasma, you would think that the half-life is shorter, but it's actually binding to its target and staying there for longer amounts of time, and so its intracellular half-life, meaning like its effect, is longer than its actual half-life. Does that make sense? This is true for all drugs that binds covalently to their targets. The drug disappears from the plasma, but it's actually still exerting its effect for a longer amount of time. Make sense? Of course, rate of resistance highly following long-term therapy. This is very true. If you take a drug for a long amount of time, the chance of developing resistance would increase. It's taken orally, excreted unchanged in the urine. Those reductions are necessary when there are moderate renal, of course, because they are excreted in the urine. If there is renal insufficiency, you would have to adjust the dose and reduce it. It's well tolerated, especially with rare occurrences of headache and dizziness. Any questions? So honestly, it's just basically the mechanism of action, because the rest are concepts. and we already covered mechanism of actions of those polymerase inhibitors. Just make sure you refresh that in your mind, okay? Any questions about this? Yes. Just mechanism of action, the fact that it has to be activated, phosphorylated to the active form. It's a prodrug. It mimics cytosine analog, okay? I don't worry much about the spectrum of activity. Of course, if we know the mechanism of action, you know which protein or which enzyme it targets, and that's it, okay? All right. Next one is entecavir, which is another drug that also acts on the DNA RNA polymerase, except it mimics the guanosine instead of the cytosine, okay? It mimics the guanosine. I can't even remember if we talked about entecavir before. Did we cover it in the antivirals? No? Okay. So it's a nucleoside, it's a guanosine nucleoside analog. Let's see, active against the ones that are resistant to the lamivudine, you would hopefully be active against, would be susceptible to this one. Excreted unchanged in the urine, of course, renal dysfunction. So concomitant administration of these drugs with renal that causes renal toxicity should be avoided. Any questions about that? So just the mechanism of action again, and the fact it's a guanosine nucleoside analog. Right, I think that's the last one. No, yeah, it is the last one. Okay, the boceprevir and the teliprevir. That's one. Okay, so these are the ones that act on the serine protease that is unique to the genotype 1 of hepatitis V. This is an important concept, okay? So just to remind you, some of those hepatitis C, some of the species are of this kind, genotype 1, and this genotype has a special protease enzyme called NS3A4A serine protease. And so there are drugs that are specific to this enzyme, and so these two are the examples of these drugs. Okay, so they attack the protease. Just to remind you, protease is an enzyme that breaks down the proteins after they're synthesized, because the viral proteins are synthesized in a single protein, and then protease cuts them into all the active form of the proteins. So if you stop that drug, or sorry, that enzyme, the viral life cycle is going to be suspended. Okay. Both are potent inhibitor. However, they have low barrier to resistance, and especially when used as a monotherapy. Okay. So they should always be combined with other agents to improve their effect and reduce the resistance. Okay. Metabolism occur via this enzyme, and so because both are strong inhibitors to that enzyme, they are partially metabolized, and they should be potential for drug interactions. Concepts, we already know that, so you don't have to memorize which drugs, which enzymes, just understand how they could interfere. Common adverse effects include anemia and this, guys, yeah, whatever that is. Associated with rash, anemia, and okay. So these are, again, I want to expect you to know the side effects too much at this point. Any questions about antivirals? Any questions about the lecture in general, about maybe exam, anything? You're good? Yes, sorry. Those two on the slide? Interferon, just the flu-like symptom, because I think we talked about it before. So the interferon causes a flu-like symptoms. No, you don't. Where was it? Yeah, just the flu-like symptom. I think it's a unique one, but don't worry about any other side effects. Okay. Any other questions? Eric? No questions. Sophia? Sophia is falling asleep probably. No questions? Are you sure? Okay, if you remember any questions, just shoot me an email, okay? All right, have a good afternoon, guys. I'll see you later. Take care.